Let's turn to a different maintenance trial, one that was presented in some way, at least preliminarily last year, called Point Break. And it's a potentially important one, asking the question of, is the standard that we developed several years ago of ECOG 4599, carbo, Taxol, Avastin, followed by Avastin maintenance, the same, better, or worse than an Alimta regimen substituted for Taxol, carbo, Alimta, and Avastin, and followed by a combination maintenance therapy with Alimta and Avastin. And a lot of people have been using this based on some early promising work that wasn't phase 3 yet. So Mary, what were the key points that you saw from it, and where might it go from here in terms of clinical implications?
Yeah, so a new analysis was presented basically looking at the endpoints in different subgroups of patients and with longer follow-up, and basically confirmed that these two regimens don't show a difference in overall survival for patients. So whether they received carbo, Taxol, Avastin, followed by Avastin maintenance, versus carbo, PEM, Avastin, followed by PEM, Avastin maintenance, the patients did not do better in terms of their overall survival in either of those groups. There was a benefit in terms of progression-free survival for the patients who were on the Alimta-based regimen. And these findings held fairly true across the subgroups. So in the younger patients, the progression-free survival looked a little bit better. In the patients who were over, I believe, 75, it looked like that benefit didn't hold up. But again, you're getting into smaller and smaller pieces of the pie at that point. So I don't think there was anything groundbreaking here at all. And I kind of see it as we just continue to have choices in our first-line therapy. And I think the trial that you presented is very similar, that we have choices that are fairly equivalent, and that we can feel good about offering different choices to our patients depending on what toxicities may be very important for that patient to avoid, what's important in that patient's life at the time. I just see it as, okay, we have choices.
Well, one implication actually that I've seen with the Point Break trial is choices being removed, because at least where I am on the West Coast in Seattle, since that has come out, many insurers have stopped covering Avastin with anything other than Taxol. They've specifically said, you can have Alimta or you can have Avastin, you can't have both. So I think that might be an implication, even if it looks like, and I think it's really a product of this view that they all get you to the same place. So, not clear that you should argue, you can't argue that one is overwhelmingly better than another if there's significant cost differences or other factors. But you mentioned the age issue. Nate, what do you think about age as a cutoff or a relative contraindication for Avastin? Because we did see a little work that suggested that beyond 70 or certainly 75, there could be a point where Avastin was not going to be helpful and may even be harmful.
Yeah, I don't think we know for sure what the right answer is with this. I think broadly, when you're treating elderly patients, almost all treatments, if you look between younger people and older people, they essentially get the same level of relative benefit of the drugs, whatever it is. And that's probably true for Avastin as well. It's still doing what it's doing, even in an elderly patient. But we do know that the toxicities are clearly higher in elderly patients. They have less physiologic reserve. Essentially, their bodies can't tolerate quite the stress that younger patients can. And so I do, in my own practice, especially people over 75, I'm very cautious about using Avastin, especially since the evidence is now suggesting that there may be alternatives that are at least comparably effective that are probably less toxic, at least in terms of the side effects that people actually care about. So while I do use Avastin, I don't use a lot of the carbotaxol Avastin. I personally feel that the side effects of the Alimta-based regimens are a little bit better tolerated in terms of the side effects people care about, and so I use that more. I have gotten the same perception that you have, though, that I'm starting to get queries from insurance companies denying Avastin when added to pemetrexed. You know what? I don't know that that's the right or the wrong thing. It's disappointing that we're taking treatments away from patients, but if we can't say that we're truly adding value, then maybe it's not wrong to take that away.
Mary, what are your thoughts specifically about the age question and Avastin? I'm sure you see a fair number of older patients where you are.
Absolutely. I mean, I think I see patients well into their 80s who are very fit. And so for the most part, I really look at the patient's comorbidities and their functional status, what they're doing on a daily basis. And then there certainly are some things that I can look at objectively, like their kidney function and those sorts of things where they're starting out. But I tend to make decisions based on their physical fitness level more than their age, because it's very difficult in Florida. We have 80-year-olds who really physiologically are like 60-year-olds and better than some of my 50-year-olds.
Yeah, absolutely. It's an issue. It's just sometimes people bring up, I mean, I think there has been good reason and the evidence has supported that functional age and performance status are more important than chronologic age. That said, an 80, 85-year-old still has an 80 or 85-year-old liver and kidneys.
Correct.
And sometimes I think all of us have, with the best intentions, turned a very functional, fit 80-year-old into a much less fit 80-year-old with a cycle or two of chemo. And, sometimes the veneer is a little thin, that's all.
Yeah,
So,
I agree. I definitely see that in my practice as well,
yeah.
for sure.
So it's a balance, fair enough. And maybe patient preference, attitude come in as well. What about this specific issue that came out of the Point Break trial? And there was a similar study, Avapearl, that looked at the question of maintenance therapy with Avastin alone or in combination with Alimta, pemetrexed. And that wasn't the only part of these trials, although that was the main purpose of the Avapearl study. The Point Break study looked at two different regimens, but a subset analysis indicated that results looked better with a combination of Alimta and Avastin in the patients who got to the point of maintenance. Do you think that's a valid analysis? Do you factor that into your equation of how you would prefer to treat patients in the maintenance setting, or how do you approach maintenance?
Yeah, I don't think I really use that particular analysis. I really use how the patient's doing after their induction therapy. And although I think the data is pretty clear that maintenance therapy overall has a benefit for patients in terms of survival, there are times when maintenance therapy just isn't practical for patients. They may be beat up from chemotherapy. They may decide that in terms of where they are in their life with their disease at that point, they need a break from treatment. So I really approach it based on how well the patient did with their frontline therapy. And in many cases, if they're on an Alimta-based frontline therapy and they're tolerating it well, then we'll choose to continue it. If they have Avastin included in their frontline therapy and they haven't had any toxicity, then we'll choose to continue it. Fortunately, in Florida, we haven't really run into some of the payer issues yet, but that may become a factor in the future in my decisions.
Nate, what are your thoughts about single agent versus combination? Are you limited by payer choices, or do you have a clear preference about a combination over Avastin alone or Alimta alone?
Well, I think that the evidence from both the Point Break and the Avapearl clearly show that chemotherapy maintenance is probably more effective than single agent Avastin maintenance in terms of prolonging the progression-free survival. Whether it really matters for overall survival, we don't really know. Generally, I kind of take into account how the patient's doing and what they're getting first line, very similar to Mary. If the patient's on a carboplatin and pemetrexed or carboplatin Alimta, I usually just continue the Alimta. If they're on carbotaxol Avastin, I continue the Avastin, but I always have in my mind, I'm not sure really how effective that single agent is. That's never been validated in a randomized placebo-controlled trial, that single agent Avastin truly benefits people in maintenance. And so I'm watching them carefully so that I can jump in with a second-line therapy if they progress. But the Point Break trial suggests that from a survival endpoint, it doesn't really matter which one you're using. So I think it's okay, at least until we have a better answer, to treat people with a variety of choices. Now, in terms of single agent and doublet, again, if I'm using carbopemetrexed Avastin, Alimta Avastin, I have been continuing the Alimta and Avastin simply because if they're doing well with it, why change what's working? I think going forward, we may not have that choice anymore. If I had to pick one of the two, though, I would drop the Avastin and continue the Alimta.
Mm-hmm. Yeah, well, I think that these studies, being as inconclusive as they are, still underscore the importance of an ECOG trial called 5508 that
Absolutely.
has patients start on carbotaxol and Avastin, the ECOG approach that they pioneered, and then switch to Alimta at maintenance, or continue on Avastin alone, as was the original study, or a third arm of the combination of Avastin and Alimta. We really need to get the results of this trial that I think flagged in its accrual because people might have presumed that we already knew the answer, and it turns out it's not as clear as we thought, and that really underscores why we need to do the study. You'd mentioned that you will sometimes give people a break. Is that something you're comfortable with? Do you think that, is it a mandate at this point to give chemo or, some form of maintenance therapy, or do you think patients can do as well with a break from that if you resume timely?
Yeah, I think patients can continue to do well if they're followed very closely and if there's good communication between the patient and me and my team. I think there are certain patients that I know maybe aren't the best at communicating and that probably the approach would not work with them. There are many patients who say, I want to go on a cruise around the world with my grandkids, and who am I to tell them they need to come in every 3 weeks and not do that when they have a disease that's going to shorten their life. So I do think that you can still do that. And, there are patients who just come in after their 4th cycle and say, I'm done. I'm done.
Yeah. Nate, what are your thoughts here?
No, I agree. Don't overlook that we actually get to know our patients pretty well on these. And there are people who I would never trust to just go off on their own. That's like, even if I'm not giving them therapy, they're going to come back and see me every month because I want to know what's going on. But there are some patients who present with what seems like a fairly indolent disease. They don't have a lot of symptoms. They get a good response to chemotherapy. They're relatively reliable. If they want to take a break, I don't have any problem with that. There are some people who stop and they would leave me and go to someone else in a minute if I wanted to stop giving them treatment. And so you take all these factors into account when you treat them. But if they need a break, I have no problem giving them a break.